The $50,000 risk, out-of-pocket exposure you didn't plan for. Here's where the math turns from annoying to dangerous. With Advantage, the premium often looks low, but the real money shows up as copays and coinsurance when care gets complex. Plans have a yearly out-of-pocket maximum for Part A and B services. Hit that and the plan pays 100% for the rest of the year. Sounds safe until you realize three things: the cap can be high, it resets every January, and not everything counts toward it. In other words, it's a trap that resets right in the middle of long treatments. That reset is the cruelest trap. You can spend thousands by December, then start over January 1 while you're still in treatment. Why this matters: serious events span months, often across a calendar year. Heart procedures, cancer treatment, joint replacement with complications, these aren't single visits. You can max the plan's in-network limit 1 year, then roll into January and start from zero while you're still in treatment. That's how families get crushed. They thought zero premium meant less risk. In practice, usage drives cost and the reset multiplies it. What counts? For Part A and B services, your plan's in-network copays and coinsurance count toward the cap. What often doesn't count is Part D drug spending, out-of-network charges in many HMOs, and any balance bills if you end up using a provider that's not contracted. If you're in a PPO with out-of-network benefits, there's usually a higher combined cap, meaning you can pay thousands more before protection kicks in. Let me show you exactly how the dollars stack. Say you have a heart event in October. You hit the ER copay, inpatient daily copays, cardiology follow-ups, imaging, and cardiac rehab. By December, you've reached the plan's in-network maximum. Relief, right? Then January 1 hits. You need a stent revision and more rehab. The counter resets. New deductibles or copays kick in and you're paying again fast. If a key specialist is out of network or your plan requires prior auth that pushes you to a different facility, your costs jump again. Now add a common twist: an out-of-network specialist consult during a complication. In many HMO Advantage plans, that's simply not covered unless it's a true emergency and you're stabilized. Even in PPOs, out-of-network coinsurance can be steep, and the higher combined out-of-pocket limit applies. One consult, one imaging session, one anesthesiologist outside the network, and you're writing checks that don't move you closer to your in-network cap. Another budget buster nobody explains: travel for covered care. If the plan directs you to an in-network facility across town or in a different county, your transportation, caregiver time off work, and lodging for early morning procedures are on you. Those don't hit the plan's cap, but they hit your wallet. And when prior authorization delays push care later, you're stacking extra visits and copays you didn't plan for. Here's a simple scenario math to make it concrete. October, ER visit, $100 $300 copay. 3-day admission with daily copays, say $300 $400 a day. Specialist visits, $40 $60 each. Imaging, $100 $400 per scan. Cardiac rehab sessions, $20 $40 per visit times 36 sessions. You're already deep into the thousands, and those are conservative numbers. January, new hospitalization, more imaging, a procedure with a percentage coinsurance, more rehab. Reset means another sprint toward the cap. 2 years like this, and you can easily cross tens of thousands out of pocket even though your premium was low. Now here's where most people mess up. They don't know their plan's exact maximum and what applies to it. Don't guess. Quick win: pull your evidence of coverage and find the maximum out-of-pocket for in-network, and if you have a PPO, the combined in- and out-of-network number. Then list which services are subject to coinsurance versus flat copays. Percentage coinsurance on big-ticket items is where you accelerate toward the cap. A second quick win: run your known conditions through the benefits. If you have diabetes, look at endocrinology visit copays, labs, CGM supplies if billed under Part B, and step therapy for newer meds. If you have orthopedic issues, price advanced imaging, injections, surgery, anesthesia, DME, and rehab. If you're a snowbird, check how out-of-area care is handled outside emergencies. Common mistakes to avoid. Thinking zero premium means cheaper overall. Premium isn't the bill that hurts, usage is. Assuming your med costs help you reach the medical cap, Part D has separate rules. Ignoring out-of-network risk in HMOs, not covered, can mean 100% you. Forgetting the calendar reset, multi-year illnesses repeat the cost cycle. If you remember nothing else, remember this: your real risk isn't the monthly premium, it's the combination of copays, coinsurance, exclusions, and timing. Know your cap, know what counts, and plan for the reset. Next, how the marketing machine pushes you toward the plans most likely to trigger those costs. The marketing playbook: why good people choose bad plans. So how did we get here? The marketing is a machine. It's designed to make zero premium feel like zero risk and extras feel like protection. If you've ever watched a football game in October, you've seen the pitch: smiling seniors, bigger dental benefits, grocery cards, a friendly number to call. None of that explains networks, authorizations, or year-to-year changes. That gap is where bad decisions happen. Why this matters: when the message is simple and emotional and the rules are complex and hidden, most people choose based on the ad, not the evidence of coverage. Add time pressure and you'll default to the easiest yes. That's not a character flaw, it's human behavior under decision fatigue. Here's the core script. It's the same as Medicare but with extra benefits. Keep your doctor, premium, call now during open enrollment. Those lines blend federal branding with private plan features and they anchor your brain on perks and price. Meanwhile, the real variables: provider networks, prior authorization lists, coinsurance on big-ticket items barely get a sentence. The tactics are everywhere: door-to-door pitches at senior buildings, call centers that confirm your information before pivoting to a sale, TV ads implying government affiliation, high-pressure reminders of use-it-or-lose-it enrollment windows. And when you say you have a doctor you love, the agent checks a directory and says they're covered. Covered where, at which facility, under which NPI? Those details rarely make it into the conversation. Regulators have noticed. The FTC has issued warning letters to companies for deceptive Medicare Advantage marketing, misleading, free language, implying federal affiliation and burying limits. Senate investigators have documented high-pressure pitches in grocery stores and call centers that blur coverage details and downplay denials and delays. The thing most people miss is how freebies shape decisions. Vision, dental cleanings, hearing aids, OTC cards, these are vivid. You can picture using them, but they're small dollar items next to a hospitalization, an MRI, a skilled nursing stay, or an infusion therapy. Plans know this. The ad shows the perk. The fine print carries the risk. There's also the fear lever. Don't overpay for Medigap. Why spend hundreds a month? We'll cap your out-of-pocket. That sounds safer than it is because the cap resets yearly and often excludes drugs and out-of-network charges. But in a 2-minute call, that nuance doesn't land. You hear savings and a ceiling. You don't hear access limits and the path you'll walk to reach that ceiling. Here's the dirty truth. Your agent often earns more if you choose Advantage. Plans get extra rebate dollars, about $2,329 per enrollee, to fund perks and lower visible premiums. The plan does better when you use less care. The agent gets paid when you enroll. Everyone profits except you when you're sick. Here's the dirty truth. Your agent often earns more for placing you in Advantage, and the plan performs better when you use less care. Everyone at the table gets paid except you when you need treatment. Perks buy attention, restrictions control costs. That's the business model. A quick win: pre-commit your decision criteria before you talk to anyone. Write down 5 non-negotiables. Your doctors and hospitals by NPI, prior authorization needs for your known conditions, MOOP amounts in network and combined, travel needs, and coinsurance on expensive services. If a plan fails 2 or more, it's a no, no matter how shiny the extras look. And remember, the extras are funded by those rebate dollars. Perks buy attention, restrictions control costs. Another protective move: slow the conversation. If someone pressures you on the phone, say, "I don't enroll over the phone. Send me the evidence of coverage and your provider verification in writing." Real plans and real agents can back up claims. High-pressure callers will pivot or disappear. That tells you everything. Now here's where most people mess up. They compare perks, not coverage. They weigh a $2,000 dental card against a 20% coinsurance on a $10,000 procedure. They accept we cover your hospital and forget the surgeon, anesthesia, radiology, and rehab each have separate contracts. They assume no referral needed means no authorization needed. Different concepts. A micro story to make this stick. A couple called after switching during a grocery store sign-up. Their cardiologist was covered, but only at a satellite clinic that didn't do procedures. The cath lab they needed was at a different facility out of network. The plan offered an in-network alternative 40 miles away. Gas, time, and stress weren't in the brochure, but they were real costs. If you remember nothing else, remember this: marketing speaks in perks and premiums. Protection lives in networks, authorizations, and coinsurance. Perks make you feel good today. Access saves you tomorrow. Here's the checklist you can use before any pitch. Verify your doctors and hospitals by NPI for your exact plan. Ask for the prior authorization list tied to your conditions. Confirm MOOP for in-network and combined if PPO and what counts. Run your current drugs through the plan's tool and check tiers and restrictions. Get provider and cost confirmations in writing. No should be covered. Choose calmly, not on a call. Compare the right things and you'll avoid the trap. How to compare plans without getting tricked. Comparison only works if you compare the right things. The mistake most people make is lining up perks and premiums. You need a checklist that mirrors how care actually happens. Keep this simple and strict so you can disqualify fast and only dig deep on finalists. Start with providers and facilities. Why? Because access drives everything else. Make a list of your current doctors by full name and NPI, plus your preferred hospitals and outpatient centers. Call each office and ask, are you in network for exact plan name and plan ID next year? Confirm the NPI they bill under and the facilities where they have privileges. If any key provider can't say yes for that specific plan, stop evaluating that plan. Don't argue with maybe. Next, pull the plan's prior authorization list. Why this matters: authorizations control timing and timing affects outcomes and cost. Look for your likely services: advanced imaging, infusions, injections, outpatient surgery, skilled nursing, home health, cardiac and cancer care. If these require prior auth, ask the plan for their clinical criteria and average turnaround times. Then ask your doctor's office if their workflow matches those timelines. If there's a mismatch, you'll feel it when you're sick. Now the money guardrail: MOOP, maximum out-of-pocket. Find the in-network cap, and if it's a PPO, the combined in- and out-of-network cap. What counts toward it? Part A and B services only or other carve-outs? Coinsurance percentages on expensive items like outpatient surgery or chemo are the accelerators that drive you to the cap. If a plan hides these details or you can't find them in the evidence of coverage, disqualify it. Transparency is a feature. Drug coverage is its own trapdoor. Run your actual medications through the plan's formulary tool, not a generic list. Check tiers, quantity limits, prior authorization, and step therapy. If you use Part B drugs, infusions, some injectables, CGM supplies, confirm medical policy rules for those too. A premium won't matter if your biologic moves from Tier 3 to Tier 5 or requires step therapy you can't tolerate. Travel and split location living can break a plan fast. Ask, what counts as urgent versus emergency out of area? Do I have routine care access when I'm away? For snowbirds, verify local access in both locations by NPI, not just a brand name hospital. Many HMOs cover emergencies out of area but push routine and follow-up back home, which isn't practical after surgery. Here's a quick, practical workflow you can use in one sitting. Build a must-have list: named doctors with NPIs, named hospitals, key services you use, top 5 meds. Pre-screen 3 plans you're considering. If 2 must-haves fail on any plan, cut it immediately. For finalists, request written confirmation, provider participation by NPI, PA requirements for your conditions, MOOP numbers, and coinsurance for high-cost services. The thing most people miss is that a no referral needed plan can still be heavy on prior authorization. Those are different levers. If you rely on imaging, procedures, or specialty meds, the PA list matters more than the referral policy. Also, don't let dental and vision distract you. If you want those perks, price them separately. Often a standalone dental plan plus Original Medicare and Medigap outperforms a perk-heavy Advantage plan when you get sick. Common mistakes to avoid. Assuming the brand means uniform coverage. Each plan ID is its own contract. Trusting the online directory without calling. Directories lag, offices know tomorrow's contracts. Weighing extras over core access. Glasses don't offset a denied MRI. Ignoring coinsurance on big-ticket services. Percentages hurt more than flat copays. Quick wins you can do this week. Download the evidence of coverage for your top 2 plans and search for maximum out-of-pocket, coinsurance, and prior authorization. Call your 2 most critical specialists and confirm next year's network status by NPI for each finalist plan. Run your meds and save the formulary screenshots with tier, PA, and step therapy flags. If you remember nothing else, remember this: decide with your real doctors, real drugs, and real services, not with ads. Your must-haves protect you, the checklist keeps you honest. Disqualify fast and only compare plans that prove they'll support the care you actually need. Your exit paths: switching back to Original Medicare. Already enrolled and feeling boxed in? You're not stuck. You have exit windows, but timing and sequencing matter. If you remember nothing else, remember this: line up Original Medicare, Part D, and Medigap in the right order and know which window you're using before you make a move. Let me lay out your main doors. Door 1, the annual enrollment period, October 15 to December 7. During this window, you can drop your Advantage plan and switch back to Original Medicare starting January 1. You can also pick a standalone Part D drug plan. Door 2, the Medicare Advantage open enrollment period, January 1 to March 31. In that window, you can leave Advantage for Original Medicare and enroll in Part D for the first of the next month. Door 3, special enrollment periods triggered by specific life events, moving out of your planned service area, losing Medicaid, plan termination, and others. Door 4, the trial right safety valve if you joined an Advantage plan when you were first eligible for Medicare. You have up to 12 months to switch back to Original Medicare and buy certain Medigap plans without medical underwriting in many cases. Now here's where most people mess up. They drop Advantage and assume Medigap is guaranteed. Outside your initial Medigap open enrollment or a protected trial right, most states allow insurers to use medical underwriting. That means they can ask health questions, charge more, or decline. So you never cancel your Advantage plan until your Medigap application is approved and your new start date is locked. Sequence protects you. Here's a clean implementation flow. Step 1, choose your window. If it's October-December, plan for a January 1 effective date. If it's January-March, your effective date is the first of the month after you switch. Step 2, pre-apply for Medigap. Work with a broker who shops multiple carriers. Ask about underwriting criteria up front. Some carriers are more lenient for certain conditions. Get a tentative approval and effective date that matches your desired start. Step 3, pick your Part D plan based on your real medications, pharmacies, and any quantity limits. Do the formulary run, save screenshots, and enroll for the same effective date. Step 4, once Medigap is approved and Part D is set, contact your Advantage plan or enroll in Part D to trigger disenrollment. Enrollment in a standalone Part D while on Advantage will automatically move you back to Original Medicare on your chosen date. Quick win: if you're within your first 12 months on Advantage, use your trial right. Ask the Medigap carrier specifically about guaranteed issue rights for your situation and which plans qualify. Get it in writing. This right can save you from underwriting landmines. What if you're past 12 months? Underwriting is the hurdle. Prepare a health history summary, diagnoses, surgeries, medications, recent hospitalizations. Shop at least 3 carriers. If one declines, try the next. Criteria differ. Ask about effective date holds so your Advantage coverage continues until the Medigap start. If your health makes approval tough, don't panic. You can still switch to Original Medicare without Medigap, but know you'll be responsible for 20% under Part B with no cap. In that case, set a reminder to reapply for Medigap after any waiting periods required by the carrier. A few protective details most people skip. Align dates precisely. Your Medigap and Part D should start the same day Original Medicare resumes as primary. Confirm Part A and Part B are active. If you ever drop Part B, re-enroll before any switch. Save every confirmation letter and screenshot. Keep your Advantage card active until 11:59 p.m. the day before your new coverage starts. Common mistakes to avoid. Dropping Advantage before Medigap approval. Always lock Medigap first. Missing the Part D enrollment. Original Medicare without Part D triggers drug costs and potential late penalties later. Assuming a state guarantee you don't actually have. Rules vary. Ask your state health insurance assistance program for your state specifics. Letting a broker pick for you without a side-by-side in writing. Require a written comparison of premiums, underwriting status, rate histories, and household discounts.